now we're going to explore life beyond the first treatment. And there was a time, and as I said at the beginning, I've had CLL for 15 years. You're going to meet someone who's had it, who's entering their third decade of CLL. That's not unusual. That it was kind of one and two, and then you were kind of out of options. But now we have way more options, and CLL, like I said, is a chess game, and you've got to make these moves. And we're going to look at life beyond that first treatment. What happens when that first treatment fails? And we're looking into those options. Think more than one therapy because we're living longer and longer with CLL. So we're going to welcome Dr. Matthew Davids and Dr. Joe Leese to discuss these issues. We'll start with Dr. Matt Davids. Dr. Matthew Davids is the Director of Clinical Research of the Division of Lymphoma at the Dana-Farber Cancer Institute and an Associate Professor of Medicine at Harvard Medical School in Boston. Dr. David has an active translational research program in chronic lymphocytic leukemia. And Dr. Davids, and just in the way of introduction, can you tell people what translational research is? That isn't English to French, right? Can you explain what that actually means in a patient-friendly way?
So first, Brian, thank you so much for having me on this very esteemed panel. And I want to send a special shout out to all the caregivers out there who are tuning in. I know this has been a particularly tough time for a lot of them because they can't come to the visits the way they always do during COVID. So we greatly appreciate your support by phone and however you're joining the visits. So I think that this is a particularly exciting time right now for CLL, and we have many, many new therapy options. It's a confusing area for a lot of patients, but hopefully we can kind of bring some clarity to that. Sorry, I carried on so long, Brian. I forgot specific for that first part.
You do translational research, but
Oh,
I don't know that most
translational
patients.
research. Yeah.
I didn't know what it was until I met people like you. Yeah.
Yeah, sorry. So really what I mean when I say translational research is that we have a research laboratory where we can study samples from our CLL patients, and we can try to understand what types of treatments we can develop based on that. And then we can actually bring that into the clinic and do early phase clinical trials with the patients, and then take more samples and figure out why certain patients may become resistant in the lab side, and then kind of get better at devising new therapies. So it's that iterative process that we call translational research.
So it's a combination of bench science and clinical science with the patient in front of you is the way I kind of think about it.
Exactly.
So we're moving on to second line therapies, and before we do that, we're developing our CLL vocabulary muscles here. We've learned a lot of new terms. Help us use some terms that docs throw around a lot, but patients may not know: relapsed, refractory, and intolerant. And because those are really important in deciding how you're going to move forward onto the next line of therapy. So tell us what the difference is between those three things.
So when I say relapse, what I mean is that a patient has previously gone into a remission with some kind of therapy. Doesn't matter whether it's chemotherapy or a novel drug, and they were in a remission for some period of time, but then the disease has come back and has started to get worse again. Refractory means that we've given a treatment and the patient never went into a response. We didn't see them, have their lymph nodes shrink the way we wanted or their blood counts improve the way we wanted. So they really didn't respond sufficiently to the therapy. So that would be a patient who's refractory to that therapy. And then intolerant would mean that we started the therapy, maybe it was helping the CLL, but the patient was having side effects that were so severe that even with adjusting the dosage or stopping the drug temporarily, we weren't able to keep the patient on the drug. So that would be intolerant.
Let me just throw it as a hypothetical, kind of a broad question here. Tell me about that conversation you're having with a patient who clearly needs a therapy because they're relapsed, refractory, or intolerant of their first therapy, and you and the patient have decided together that therapy. What testing do you want to do when somebody's needing a second therapy? What testing do they have to have repeated at that time?
So, there's a couple of aspects to that, and one of them is kind of influencing the decision of when to retreat or when to treat again. And so, getting a sense for the disease burden of the patient, and that could be obviously with blood counts, but in some cases also CAT scans or a bone marrow biopsy if a patient has anemia or low platelets to kind of understand the burden of disease and whether treatment is needed at that time. And then once we've decided that we want to move, it is important to retest some of the prognostic tests that I think you discussed in the last session, in particular the FISH test. That's the one that's looking at the different chromosomes in the CLL cells, because that can actually change over time. And when it might have been a more benign FISH test early on, particularly if a patient's undergone chemoimmunotherapy, when the disease comes back, sometimes we see more sinister abnormalities like 17p that can arise. I would also say, when possible, it's helpful to do sequencing tests for TP53 because this is another genetic mutation that can arise, and it can influence both the next specific treatment that we choose and also treatments down the line, as well as the prognosis for the patient.
So it sounds like what the testing results are is going to be one factor in the decision. Tell us how you're looking at the patient, how conversation goes. You've had a patient who's needs a therapy. Let's say that they've relapsed after treatment, and now it's time to look at something new. First, is it the same decisions that you're making in terms of when to treat that patient, or do they have to become, this is, we got into a little bit in our last discussion, do you wait until they're symptomatic again? Or, and I'm asking you a question that I asked Dr. Flynn and Dr. Mato, so I'm getting your take on this too. Or does it make sense with the great treatments we have to, we're seeing a hint of the disease coming back, let's kick it while it's down and not wait until you're symptomatic again? How do you have that discussion with that patient?
So traditionally, the way that the trials have been designed, that we've gotten the data for all these therapies, has been that patients need to meet those same IWCLL criteria that they met for initial treatment at the time when relapse treatment is needed. And so, they need to have either symptoms or very large lymph nodes or spleen that are causing symptoms, or very low blood counts, anemia, or low platelets. So as of right now, we don't have any data to suggest that if we treat earlier, for example, at the first sign of relapse, that we can prolong the survival of patients compared to if we wait until they have more symptoms. And I think it's important to wait because the treatment landscape is evolving so quickly. And I've had patients who've developed early signs of relapse, and they've gone a couple of years before they actually required therapy. And if you understand how quickly the field is moving, a couple of years means there could be a whole another option that's not available at the previous time. So I do tend to wait until patients are having more symptoms. That being said, I might not wait quite as long as I've waited in the frontline setting. So there is a little bit of nuance there as to when to get started. And I would say personally, I'm a little bit more proactive in getting started in patients who have relapse disease.
So let's hold off on talking about clinical trials, and I'm going to get to that next. But tell me about what factors you look at when you have the patient in front of you. And maybe we can, this is getting a little beyond this topic, but maybe talk a little bit about sequencing. Because I know at Dana-Farber, you and Dr. Jennifer Brown have been very interested in how you sequence drugs and what might give the best long play for the patient, in terms of this drug, then that drug, knowing that one is going to lead to another eventually.
Right. And I like the analogy of the chess game, because in chess, we don't just think about the next move, but we think about the next move after that and after that. So I think as CLL specialists, we're trying to plan out the next several lines of therapy. And, each time we meet with a patient, that might be slightly different based on how the field is evolving. But, I think that to me, when I'm sitting with a patient who has relapse disease, one of the first factors that I consider in my recommendations for the next line of therapy is just a simple thing, which is, what did they get in the frontline setting? You know, did they previously have just ibrutinib? Uh, Obviously, if they're progressing on ibrutinib, I'm not going to then use ibrutinib again, so I need to think of other options. But on the other hand, if they had chemoimmunotherapy and went into remission for a few years, and then the disease started to come back, then really everything is on the table at that point. And so ibrutinib or acalabrutinib becomes a great option. But we also now have the data with venetoclax and rituximab as a time-limited therapy. And so that's often sort of an initial discussion I'll have with patients to understand what their preferences are. Some patients have strong feelings that they like the idea of being on a continuous therapy for many years because they feel secure that they're on their drugs and the disease is well controlled. But I have other patients who would rather just do a time-limited therapy. Maybe they had a good experience with their chemoimmunotherapy, and now they like the idea of venetoclax treatment, where it's 2 years, and you know that you'll stop if you're doing well at that point, and you may enjoy several years of remission without the need for ongoing therapy. So I think the patient preferences at this point are very important because we don't have head-to-head data yet of this strategy of the continuous ibrutinib or acalabrutinib versus the venetoclax-based treatment. We also think about what other medical issues the patients have. So if it's a patient who unfortunately has cardiovascular disease, maybe they're already in atrial fibrillation and on a blood thinning medicine, that points us more toward the venetoclax approach because that drug doesn't have risks of those. On the other hand, sometimes patients have kidney issues, and we worry about some of the risks around the tumor lysis with venetoclax, and so we steer them more toward the BTK
So
inhibitor drugs like
remind
ibrutinib.
us, Dr. Davids, remind us tumor lysis and talk a little bit about that ramp up with venetoclax, if you could cover that and sort of it's a double-edged sword, the good and bad of tumor lysis, if you could walk us through that, please.
Sure. So what tumor lysis means is basically the tumor cells are bursting open so quickly after a treatment is given that they are releasing their toxins into the bloodstream. And if it happens too quickly, sometimes the kidneys can't process the toxins fast enough, and patients can get very sick from this. I mean, this can even be a life-threatening condition. And when we first were developing venetoclax in the early days and figuring out how to dose the drug, we had some serious cases of tumor lysis syndrome. And so at that time the studies to study a very low dose of venetoclax that was slowly ramped up week by week with careful monitoring. And fortunately, by doing it that way, it actually was very safe. And we very rarely see tumor lysis now, but it does require pretty good monitoring in terms of blood work to make sure the electrolytes look okay. Patients need to stay very well hydrated, and they need to go through this
So
several-week process to start on the drug.
electrolytes are like the sodium, potassium, chloride, these things that you're talking about there.
That's
The
right. Exactly.
salts in the blood, essentially. Yeah. And
Yep.
talk to me, the usual pattern is just because of the history of the approvals has been that people start on ibrutinib, and if that stops working, then they go to venetoclax. That's a usual pattern. But what about the other way around? You must be seeing that more now, people who start on venetoclax. Talk to us about someone who's had venetoclax but now needs a second therapy.
Yeah. So, at this point, we don't have a what we call a prospective clinical trial, which is we've done that question. We've looked for that question of patients who have had only venetoclax who then go to ibrutinib and trying to understand how effective it is. But we do have a number of what we call retrospective studies, meaning we look back after the fact, and we can see now in several different data sets. There's a relatively large data set from the group in Australia. There's a group that Anthony Mato, who you just heard from, looked at in his database, and then a few other select situations where we do see this pattern of using venetoclax first and then ibrutinib, and it seems like the ibrutinib is very effective after venetoclax. So that is providing a reassurance that we probably can go in either direction in terms of the order of administration, and patients can do very well.
All right, we have a little less than 2 minutes left, which isn't enough time, but I'm wondering if there's a trial or two that you want to highlight for patients to think about if they're looking at a second line therapy. Let's say they've had ibrutinib or acalabrutinib as a first line therapy, and now they're going to need a second line therapy. Is there a trial you have at Dana-Farber or that's across the country that you think patients should seriously consider?
Yeah, so I think specifically for the BTK progressing population, maybe a couple trials that I can highlight. So I think one really promising approach is to find new combination partners for venetoclax. The approved regimen is with rituximab, which is good, but we think we can do even better. And so, for example, we have a combination of duvelisib, which is a PI3 kinase inhibitor drug, a completely different mechanism, combined with venetoclax. So we call it D plus V for duvelisib plus venetoclax. And one of the advantages of this regimen is that it's all oral drugs as opposed to the rituximab infusions. Another advantage is the way we designed the study, it's a 1-year therapy instead of a 2-year therapy. And so far, we're seeing very promising results. It's been a very effective combination. There's other studies going around the country looking at other PI3 kinase inhibitor drugs, for example, umbralisib with venetoclax, which is also a promising strategy. And then the other one that I would mention briefly that I think you just heard from Anthony Mato is the LOXO 305 study and the ARQ-531 studies. And these are the new BTK inhibitor drugs, which may be very effective for patients progressing on ibrutinib or acalabrutinib.
All right. Well, stick around because we're going to get Jolise to talk next about third line and later therapies as we deepen our journey, and we'll have time, a lot of time for Q&A. And please ask, I'm asking people, send in your questions. They seem to have slowed down a little bit, so send in some more questions to us, and we will try to get in. Dr. Leese and Dr. Uh, Davids, be prepared for questions across the whole spectrum of CLL, because we're going to throw everything at you. So we're going to move forward now, and I'm going to talk about third line therapies. And we have, uh, 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 we're very lucky to have Dr. Joe Leese. Dr. Joe Leese is a consultant at the Division of Hematology Oncology at Mayo Clinic, but not in Rochester, Minnesota, but in Arizona. Probably a smarter choice
Warm
of where to
Arizona.
be. Yeah, he holds an academic degree of an assistant professor of medicine, Mayo Clinical College of Medicine and Science. He focuses on CLL, adoptive immunotherapy, and I'm going to ask you what that is, and something that we're going to dig into a little bit is cell transplants, hemopoietic stem cell transplants, or and what that role is. Dr. Leese, thanks so much for joining us. What
My
is
my pleasure.
adoptive What is adoptive immunotherapy? What does that mean?
It's a broad term that looks at using cells to elicit an immune response against a specific tumor type, in this case CLL. The first incarnation of this was stem cells and allogeneic stem cell transplant, where you get stem cells from another donor that matches your immune system. But now there's other variations of that, something called CAR T, or chimeric antigen receptor T cells, where you take the lymphocytes out, your own lymphocytes, modify those, and so that now they are attracted to the CLL cells, and then give them back to yourself after a specific treatment. And so there are different ways of modulating cells that will allow for either what we call a graft versus leukemia effect from the stem cells that an immune system you get from a donor, or modifying your own cells so that you can elicit an anti-tumor effect.
So let's talk a little bit about those cellular therapies. And Dr. Frieda from UPenn is going to be talking a little bit more about the actual technology and putting those together. But maybe we can cover a little bit of the clinical part. First, allogeneic, that means from someone else. So these aren't harvested from the patients like they are in other blood cancers, but you need a donor, sometimes a sibling or an unrelated donor. What Transplants used to be a fairly significant part. I myself had a bone marrow transplant as part of seeing a lot of those today. Where do you see the role of transplants fitting in CLL these days, Dr. Leese?
Yeah, great question. So transplant remains the only definitive curative therapy so far for CLL. There's great progress being made and MRD negativity, which you heard about earlier, by combining the new novel therapies that target different pathways. But we've known for decades now that transplant can cure patients. Initially, transplant was done by giving patients very high doses of chemotherapy targeted knocking out their own immune system and the disease itself, and then repopulating with someone else's immune system. Now, there's a 25% chance that any of your siblings may be a full match, and inherit your immune system markers from your parents. And now there are about 35, 36 million people who have volunteered to be donors, and they're put into a registry. And then we tried to match the immune system markers of yourself with somebody in that pool, and that's what's called the match unrelated donor stem cell transplant. So both of these have been effective. What the problem with initially was that older patients who typically get CLL don't tolerate high doses of chemotherapy. And so in the late 1990s, early 2000s, new approaches were developed to allow for reduced intensity conditioning regimens, milder chemotherapy regimens, and even something developed initially in Seattle by Rainer Storb and his group to do an non-myeloablative transplant, where you just give enough chemo to knock down the immune system to allow the new one to take, and then when that takes, that will serve as the actual treatment. We've learned that CLL is particularly amenable to something that we call graft versus leukemia effect, the new immune system attacking the leukemia cells and getting rid of that. And so modern transplant trials showed approximately 50% long-term survival with doing this. And there's been trials that have been followed for 20 years now showing that about 50%, 40 to 50% of the patients can be cured of their CLL.
So let me push on that a little bit, and that's two
Mm-hmm.
things. What we call treatment-related mortality, which means you die from the therapy. That's
Right.
gotten a lot better in transplants. In graft versus leukemia, we want, but graft versus host. Can you remind us what graft versus host is and how frequent of a problem that is? And has it gotten better in terms of the management?
Yeah, so what are the potential complications? Why don't we, if we've got a curative therapy, why aren't we doing it for everybody? And the reason is that there are complications and something we call non-relapse mortality. What's the potential that you could die from the transplant? And it can range anywhere from 20 to 40%, depending on how good a donor you had. And so when you've got these new novel therapies that are leading to responses in 80, 90% of the patients, and they can be durable, lasting for several years at the minimum. You don't want to subject somebody to a procedure that potentially could kill them. And so there are complications. What are some of those complications? One of the major ones is what we call graft versus host disease. Despite the fact that we can match the major immune markers, the immune systems are more sensitive. They can detect differences between male and female cells. If you happen to have a opposite, they can detect what we call minor markers on the surface. And in essence, they will attack your own tissues when you get somebody else's immune system in there. And as part of that is really good because where it's attacking the CLL cells, which we call graft versus leukemia effect, that will knock that part of it out. But if it attacks a vital organ, your GI tract, your liver, your skin, then that can be a major problem, particularly if it's severe. And severe graft versus host disease can lead to increasing what's called transplant-related mortality. And that contributes to that 20 to 40% of the patients that can die from the transplant process. Infection also plays a role because you're knocking out an immune system completely. You don't have any, and now you're trying to have a new one take. And in that process of that new one taking, that can be times and gaps where you don't have an adequate immune system, so infection risk increases as well.
And that must be particularly from when I had my transplant. I was in these reverse isolation rooms with negative air pressure and all this stuff going on to protect me. So in some ways you're safer, but at some point you got to be kicked out of the hospital and sent home.
Yeah, absolutely. I can tell you that we're a large transplant center that's continuing in other diseases. You mentioned earlier that transplants have decreased in CLL. And really, data that was developed in the early 2000s showed that patients with 17p deletion or p53 mutations were the highest risk after chemotherapy, chemoimmunotherapy, or relapse quickly after purine analogs like fludarabine. Those were the people that we targeted for transplants. So transplants peaked around 2010, 2011 at about 500 a year in the U.S. and starting with a clinical trial. Now you had something new, and so now about 100 transplants are done yearly. We have not seen transplant patients from the get-go have been very careful. They've always been wearing masks. They've always been doing this. So we very rarely see COVID-19 infections in our transplant patients, despite the fact that their immune systems are down and they're on immunosuppressive medications.
Well, I'm going to move a little bit, and if we have time, we'll get back to CAR T. But I wanted to ask about non-cellular therapy. Dr. Davids mentioned PI3 kinase inhibitors, and that's often
Right.
a third line option, duvelisib. Could you talk to us, and there's others in development, could you talk to us about what a PI3 kinase inhibitor is and how they play into your management of a CLL patient who's now three or four, they're in the middle of their chess game right now. They're not at the beginning. They're not, they're not pushing their pawns forward. What do you do there?
Yeah, so great question. So PI3 kinase inhibitors block a enzyme called PI3 kinase, and there's some different subunits of that different ones will hit. The first one was idelalisib, which was FDA approved around 2016. And that in combination with rituximab, these worked against the high-risk CLL with 17p deletion and p53 mutations. Now, what stimulates the CLL cell to grow are related to the different pathways. And one of those pathways that ibrutinib hits it turns on genes that increase factors like interleukin 2 that propagate CLL cells. Well, another pathway that goes through the PI3 kinase and mTOR. And that pathway also contributes factors that will propagate CLL cells to grow. And by giving these and blocking that pathway, you can keep that from happening. Now, there have not been head-to-head comparisons between BTK inhibitors, venetoclax, which blocks a separate pathway, the BCL2 pathway, or the PI3 kinase to show. But Dr. Meadows' data and others suggest that sequencing is important. We know that, for instance, if you look in retrospective studies, if you started with a BTK inhibitor like ibrutinib, and then you ask what works best as second line, venetoclax or idelalisib, there's data from Jones, Coutre, and others that suggests that venetoclax response is going to be very high. 75% or greater will respond in that situation. But the PI3 kinase with blockade with idelalisib may not be quite as high. Now, the idelalisib has some problems with it, colitis particularly, and so other
Remind
PI3
us what
kinase inhibitors.
colitis,
That's
Dr. Leese,
inflammation
remind
of
us
the
what colitis.
colon. Yeah, yeah, that's inflammation of the
Yeah,
colon and swelling of the colon, and that can be life-threatening in some cases. So people try to develop better PI3 kinase inhibitors that had less side effects like that. And duvelisib is one of those that targets two of the subunits of the PI3 kinase. And that has less effect from the standpoint of a little bit less of that inflammation of the colon, GI tract, and is a little bit better tolerated. So it can be used in this setting. And then clinical trials, there are many options. Dr. Davids mentioned a couple which are very good in the second and third line setting, and others that are being used in this setting, particularly the novel BTK inhibitors that do work in BTK to ibrutinib and acalabrutinib.
so let me ask about that combinations. And I've known anecdotal evidence, and I know that there's some trials that are going on, small trials, where patients have failed ibrutinib, failed venetoclax, but are being now looked at using those two drugs together in combination. Do you ever see that as an option for patients? Or with venetoclax in particular, people say maybe we could re-challenge them if they've gone a couple years in with a remission. We could try it again and see if it works. I know people used to do that with FCR, try a second course if people got a durable remission out of the first course. Do we look at that with any of the novel therapies, reusing them or reusing them in combos?
Yeah, yes. The answer is yes. I've done it, and many people have done that as well. So one of the interesting effects that we've seen is that you can be on ibrutinib, you develop a mutation that makes you resistant to that, and then you start on venetoclax. You go for several years with a good response, and now you start progressing. And interestingly, despite the fact you have a mutation that makes you resistant and the disease was progressing on ibrutinib, when you throw that back into the mix, a subset of patients will respond to that. And by blocking both of the pathways, even though it's not 100% efficient in either, you can still get a transient response. When we've looked at this here at Mayo, generally it's short-lived. I would say 12 months has been our experience at the most. And so we want to be thinking about where we're going to be going next. The mention of the chess pieces and the chess game is exactly what we're thinking about. Um, so you can do that. The novel BTK inhibitors like LOXO and ARQ-531 don't rely on the same mechanism that ibrutinib and acalabrutinib do, and they're highly effective in blocking BTK again, and in a different manner. Competitive inhibition. They work sort of like the old CML, the CML BTK inhibitors like imatinib, dasatinib, nilotinib, and they are effective again in this setting. So using those in clinical trials have been highly effective. And then combinations. Dr. Mato is lead investigator on one that we're participating in called the D15 study, where a BTK inhibitor, an mTOR inhibitor, everolimus, again targeting the PI3 kinase mTOR pathway, and then a immune system booster, pomalidomide. Combining those three is showing very, very good effects in patients with CLL, and particularly those that have transformed to Richter's transformation.
All right. I think we're going to move on to the Q&A, and I'll call Dr. Davids back into this, and we'll have some time to answer people questions. So thank you so much for that, Dr. Leese. That's a lot of stuff to cover. And if I could get Jason to reset my clock so I know exactly how much time I have for Q&A, because I'm getting some conflicting clock. All right. So, okay, so let me ask a couple questions here. You mentioned a drug at the end, Dr. Leese, pomalidomide. And I remember a drug called lenalidomide or Revlimid that looked very promising in CLL. And they were called immune modulating drugs. But they seem to have kind of disappeared from the CLL landscape. Are they having a resurgence? Is there a role for these drugs? Can you help patients understand what these drugs are and what their role might be?
Sure. So these are called immune modulating drugs. They work through pathways that seem to enhance the immune system. By themselves, they will sometimes cause a tumor flare because the immune system cells that are in the CLL nodes can expand rapidly and cause some issues with patients, but that's usually a sign of a good response. So by themselves, they don't have long-term effect, but there's been studies and they've been approved for use in maintenance post chemoimmunotherapy regimens. Lenalidomide is the one that was approved for that. So they're starting to regain a little bit of momentum in the setting of combinations and some of the clinical trials. I don't think that they're agents that are particularly useful by themselves. I have had, 10 years ago, I would try somebody who had failed everything on lenalidomide, and sometimes they may keep the disease in check for a year or two. but putting them into combinations is showing some interesting effects.
And I know that they even use thalidomide, which of course is notorious for its effect on birth defects. Yeah, and it had some activity too in CLL. Uh, Dr. Davids, I got a couple questions about zanubrutinib, which is approved in another B cell cancer, but not in CLL. Is that a drug that people could use, and where would that fit in to your treatment options for a patient?
Yeah, so we're very fortunate to have several BTK inhibitors now to choose from, and zanubrutinib is another great drug that I've used before in some of my patients. It's technically off-label use right now because it's not formally approved by the FDA for CLL, but as you said, it's approved in a different lymphoma, so we can access it if we want to. I would think of it as a drug that's relatively similar to acalabrutinib in the sense that it's highly effective, just like ibrutinib and acalabrutinib, but tends to have a little bit better side effect profile from what we can see. And it's actually been compared head to head to ibrutinib in a large study in Waldenstrom's, a different disease. But in that study, they did show that there was an improved safety profile for zanubrutinib compared to ibrutinib. So it's a good option to consider. It's not yet approved in CLL, although likely we'll get a label in CLL soon.
If a patient has, you follow up on this, Matt, if a patient has progressed on ibrutinib, would they respond to acalabrutinib or zanubrutinib?
So unfortunately, no. That has been looked at, and we're already starting to see some of the same mutations in patients, for example, on acalabrutinib when they become resistant, as we saw with ibrutinib. So I would not suggest switching from ibrutinib to either acalabrutinib or zanubrutinib in the case of progression. But we do have good data to suggest that if someone has to come off of ibrutinib because of a side effect, that they can do very well on acalabrutinib or zanubrutinib.
Dr. Leese, we open a little bit of a can of worms here. What does immune modulation mean when we talk about that? Can you explain that? And if you can explain it, I would love to know, because I always thought it was kind of a hand waving, kind of term, But we're trying to increase people's
Yeah, that.
vocabulary here.
Yeah. Yeah,
Go
so
ahead.
very, very good question. So I'm going to rely mainly on the work that's been done by Ramsey and John Gribben in the UK, so often in tumors, including CLL nodes, there are T lymphocytes that are in that something tumor infiltrating lymphocytes, and what lenalidomide and pomalidomide do appears to change the function of those T lymphocytes to be better at attacking the tumors and the leukemia cells. And it changes the surface of the cell, the mobility of different things, something called cap proteins and others, and seems to elicit a immune reaction so that you have a better tumor kill. And so that's one way of modulating that it modulates the immune system.
All right, and let me ask you about the PI3 kinases, which we talked about, idelalisib and duvelisib, and there's another one, umbralisib, which is in development coming, and I'm sure there's others being. He has autoimmune issues. Does that give you pause to use a PI3 kinase inhibitor? Dr.
For me,
Leese?
Who are
Brian.
you asking the?
Oh, sorry. Yeah.
Yeah, go ahead,
Dr.
Matt.
Leese, yeah. Are
Oh,
you, if you
okay.
want to answer it, Matt, that's
Wasn't
fine
sure
too.
who.
Yeah. Yeah.
Go ahead, Matt.
Yeah.
Yeah, I mean, certainly that does give me pause. It's really the types of side effects that we see with these drugs are autoimmune in nature. So if I have a patient who's already had issues, for example, with ulcerative colitis, it's not that I would never use a PI3 kinase inhibitor in that patient, but I'd probably want to exhaust all of the other options first and kind of use that more of a last resort.
And
I
Dr.
agree with
Leese, you
that.
want to add anything to that? Yeah. All right.
No, I mean I completely agree with that.
what we see in the community is a lot of single use of monoclonal antibodies like rituximab or obinutuzumab, but we don't see that with CLL experts very much. Could you address that issue? I mean, I can't imagine must have a ton of patients who've come to you who've had rituximab as their only therapy, and maybe now obinutuzumab. What about these agents? Because they seem so helpful when they're added to another therapy, but less helpful when they're used on their own. So maybe I'll have Dr. Leese start with the idea of monoclonal antibodies as single therapy in both maybe an upfront and in a relapse setting. Yeah.
Yeah. So it's something that we never do. Uh, the back about 2002, one of the CLL scientists, Hainsworth, tried this and showed that there was approximately a third of the patients who could get a good response, and in upfront setting, it could be 50 to 60% of the patients would have a transient response. And so it would always come back. Keating and the MD Anderson groups showed that sometimes you would lose the CD20 expression. And it's very clear that the synergistic effect of adding rituximab to chemoimmunotherapy it had a very potent increase in the response rates. And so I never did that to just use a monoclonal antibody. Now obinutuzumab Gazyva has been engineered to be better. It sticks onto the CLL cells a little bit better, and the response rates are a little bit higher if you use it, but it's again transient, and there's a potential that you would lose that effect. Now, the question of whether antibodies enhance the new oral targeted therapies is not as clear as it was with regimens like FCR and rituximab bendamustine. You have a situation where the like the Jennifer Wyash, the Alliance trial, which compared rituximab plus ibrutinib alone versus rituximab bendamustine, showed that ibrutinib and ibrutinib rituximab basically gave you the same result. Other data from Jan Berger at MD Anderson showed the same thing as well. And so are these monoclonal antibodies as important in combinations? It's not in my mind. But we don't do that. I see it all the time. I grant you on that. But for various reasons, I don't think that that's an appropriate way to treat patients now.
Well, I'm going to put you on the spot here, Dr. Leese, in a minute and a half. Umbilical cord blood is a source for bone marrow transplants. Is that an option for CLL patients? What's the status there?
Yeah, so umbilical cord blood is another way of getting stem cells. There are some difficulties because you need to have a certain number of stem cells, and often if you weigh over 50 to 60 kilograms, which is about 130 pounds, there may not be enough to do umbilical cord blood from a single unit, and you may have to get two different units. But it's very clear that both haploidentical transplant, where you get a half mismatched sibling or parent or child for that matter, versus versus doing cord blood versus doing unrelated are starting to give about the same results. And so now that we can do haploidentical transplants, that's preferred because of the cost and of acquiring cells from umbilical cord blood. And so there's alternatives to doing that. And I think the numbers for umbilical cord blood transplants have gone down. Now, they have the advantage that they're much less likely to cause graft versus host disease. And in fact, everybody's mismatched at immune system markers when you do umbilical cord blood. But I think the numbers really show that that's waning.
Dr. Leese, Dr. Davids, I think we're finishing up our CLL journey, and we've covered a ton of material. Thank you so much for this, and I so appreciate your time and the research you're both doing, and I look forward to connecting in person at some point again soon. Thanks very much.